Thank you, Irfan. Good morning, everyone. So you're all set to go back home? Or not yet? All right, so today we're going to talk about, as you can see, that the title of the talk, it says Translational Nanomedicine. That means we'll be talking about something which is more close to clinic. And we'll also talk about how chemistry, biology, and engineering can all be combined together to help achieve that. I'm part of bioengineering, as Dr. Ahmed mentioned, and also I'm part of Beckman Institute, and my lab is in Carl Foundation Hospital, and some of you might have already visited the place yesterday. And these are my disclosures that I need to mention these. So as we all know that, so what is nanomedicine? So nanomedicine is basically, as you can understand, that it's combining nanotechnology with medicine. Simple, right? And you have heard that nanomedicine may change the healthcare. Now, the field of nanomedicine is really huge, and although we're interested in all parts of it, we are trying to understand how these tiny particles can help us move from the symptomatic medicine to the preemptive medicine. So what is a symptomatic medicine and what is a preemptive medicine? So in the symptomatic medicine, it begins with the clinical symptom, and that may lead to a chronic disease where there is no coming back. Whereas in the preemptive medicine, that pretty much starts with the screening of the disease, followed by an early diagnosis, and then based on that, a preventive treatment can be applied. So now there's been a growing interest over a decade, I would say, in this field, and as you can see here, not only within the research community, but also within the public domain. Like here, this is a cover story of 2009 Time magazine, which talks about how to stop heart attack by doing some advanced imaging technique. So basically, the goal is how can we use these tiny nanometer-sized agents to obtain some functional and quantitative imaging information, localizing the disease. And based on that, a minimally invasive treatment can be applied, and then we will follow the disease response to the therapy. And the bottom line is the whole treatment that can be tailored to the patient. So if we replace this graph, then this is a very nice graph that I took from Wikipedia, which shows how molecular imaging and therapy might work, where, if you think about a patient whose cancer has been diagnosed, and then we have a very sophisticated, smart agent that knows where to go, and that will be applied, and then during circulation it will find the tumor, it will bind to the tumor, and then we will image the patient, we will identify the tumor here, and then we will start applying some localized therapy. And then again, we will do imaging to see whether the tumor has been reduced or not. And then finally, the patient will be cured. Sounds very simple, right? It turns out it's not that simple. Why? Because we need to have a really deep understanding of the root cause of the disease, and when we're talking about when we're talking about early detection, that means we're talking about some of the biochemical things that happens even before the actual manifestation of the disease. So we are talking about linking the symptoms to the molecular origin. And of course, the main challenge is to bring a bench-side science to clinic, because we might be doing a lot of cool stuff in the lab, doing in vitro stuff, preclinical stuff, but at the end of the day, it don't matter unless you translate it to the human. So this is what I call a holy grail in nanomedicine research. So what are we really after? So we're trying to find a target. We want to detect it early. we want to quantify the disease site, and that will exactly tell you whether the disease is in a very early stage or it has progressed. Then we want to deliver a drug and then release the drug, follow the drug response, and then perform all these things with a safer cargo. So we're going to need a suitable marker and a high affinity ligand. So preferably we use the peptides or peptidomimetics. We may not be interested in using antibodies because those are kind of difficult to translate because of a lot of different reasons. And then the affinity should be in a nanomolar range because we are talking about detecting a cancer target which is at a very early stage. That means when the expression in the cancer cell would be very low, and that would be in a very, very tiny in nanomolar range. Sensitive imaging modality, which can identify the disease, an imaging technique that can provide quantitative information, and deliver the therapeutics affecting the normal cell very little or none. And then we would be interested in a carrier that is extremely robust, that will not do anything when it will be injected in a patient. Now, let's see how we can, I call it a packaging industry. And then how the better you can package it, the smarter we can package it, the better result you can obtain. So let's see how we can package it in a very sensitive, efficacious, yet a safer way. So what exactly is nano? I mean, you guys have been hearing a lot of talks, so let's hear it from you. Anyone? What is nano? What do you think nano is? Something what? Wow, you guys are good. Yeah, you know. So most of the times when I ask this question and I get answer like this, or this, or someone from Cleveland gave me answer this, and someone gave me answer this, you know, but you guys are good. So, okay, so we don't have to go over that, but briefly, in a world of nano, as we know, that the term nano comes from a Greek word. It's a Greek word. It's called a dwarf. That means tiny, small. And like he said, that it's 10 to the power 9 meter. And in a size scale, in a real world scenario, if you think about it, then humans are 10 to the power 7 times smaller than the Earth. And if you compare it with a 100 nanometer particle, and that would be 10 to the power 7 times smaller than a human. So it's a really huge difference that we are talking about. So why are we interested in scaling down? Because when we scale down, we achieve high surface area, and that gives us the opportunity to put a lot more drugs or contrast agents. So high payload, multifunctionality, and as a result of all of these, we achieve a low overall therapeutics per nanoparticle. So at a nanoscale, a lot of different properties also arise, and that could be, you know, chemical properties, physical properties, electronic properties, and all that kind of stuff. So we can also exploit those properties for our nanomedicinal application. Now, can you tell me that is this something that we're doing, it's really new? It's probably not, because you know, the examples of nanomedicine goes back to you know, like ancient civilizations. So here, as you can see here, that this is lead sulfide crystals, 5 nanometer, and Egyptians, they used to use this to blonde their hair, you know, to color their blonde hairs. So that's and they used to use lead sulfide crystals at 5 nanometer size. And you know, like some of these, like silver nano-colloids or gold nano-colloids, they were used by Persians or Babylonian and Greek civilizations as antibiotics. And these are not from them, but I think I found it online, and I wouldn't recommend you taking these as an antibiotic. So just so you know, but the bottom line is, that it's over 4,000 years old, and it goes back to ancient Egyptian and Persian times. So it's something new that we are doing. We're probably doing something which we are trying to understand the potential of the whole thing even better. So we're not doing something new, and here's one movie that I want to show you, and that will tell you that, you know, even before all these smart scientists came up with nanotechnology.
Based on our latest communication, we can assume that the Borg survived the fleet's attack. Your thoughts on our next encounter?
What about the heavy graviton beam we were talking about?
I've gone over it 4 times. The local field distortion just wouldn't be strong enough to incapacitate them.
Dr. Crusher and I have been working on an interesting premise.
With our recent experience in nanotechnology, we might be able to introduce a destructive breed of nanites into the Borg.
Nanites?
Robots, small enough to enter living cells.
How long would it take to execute that?
That's the problem, 2 to 3 weeks.
In 2 or 3 weeks, nanites may be all that's left of the Federation.
Nanites?
Robots.
I think you got the idea that, you know, the Hollywood people, they're smarter than us, really. So they made it so simple, but again, 2 to 3 weeks, that's way too long. We cannot wait that long. I mean, we gotta get something which works even faster, right? But the concept is out there, so we're not doing anything really super, you know, something really new. Anyway, that's just for fun. So this is what we're looking at. So we'll come up with some engineered particle with a theranostic application. Now, the term theranostic, how many of you know the term theranostic? Good. What is it?
Combination of therapeutics and diagnostics.
Okay.
Like combining fluorescence and
Okay. Sure. So you think why it's theranostic and why it's not diaputonostic? It's a trick question. I mean, ideally, we're talking about detection and then therapy and then detection, right? So it should be diagnostic, therapy, diagnostic. So diaputonostic. But somebody call it diaputonostic. But you're absolutely right. So theranostic is a combination of therapy and diagnostic. It's a very catch term these days, and it tells you that about an agent that has the capability of doing both the function equally well. So what will happen that you'll have a smart agent, and that will carry a homing agent. I call it homing agent. It's a kind of a GPS that will take you to the right cell. Either you're targeting cancer or you're targeting some cardiovascular event. Then it will go there and bind that particular receptor, and then you will have some kind of a contrast agents, and it really depends on what kind of imaging modality you are going after. If you're using MRI, then it will be some paramagnetic or super paramagnetic metals. If you're going after optical, like you said, it will be some fluorescence or some other quantum dots particle or something else. If you're going after computed tomographic or CT imaging, then you will have heavy metals and all these. So it really depends, and you can tune these things. Then you have therapeutics. You can load different kinds of drugs or prodrugs, and we can also think about gene delivery stuff as well. And the size limit that is a 20 to 200 nanometer size, and by definition, nanometer, anything beyond 100 nanometers, probably they call it nano. But in some application areas, for specifically in the cardiovascular, if you have some target which is within the vasculature, then you'd like the particle to be restricted within the vasculature, and you don't want them to leave. So then you have to have some kind of a size cutoff, and that's when these 200 nanometer size particles are very highly beneficial. So we'll talk about those things. And these particles can be made out of soft materials, and we typically like lipids or even a polymer like self-assembled nanoparticles. So I'll try to give you a brief, examples of some cancer and cardiovascular stuff that my lab has been doing. And as part of I recently moved from Washington University, so part of the work was done over there and part here, so it's kind of all combined. So before we do all kinds of preclinical experiments or go for phase 1, phase 2 clinical trials, we try to get an understanding of the particles through their physicochemical characterization, like size distribution, molecular weight, solubility, surface chemistry, and all that kind of stuff. And then we do some in vitro studies to understand their binding, pharmacology, blood contact properties, cellular uptake, cytotoxicity. And then we go for in vivo, where we try to understand their pharmacokinetics, tissue distribution, whether these particles are being excreted properly, and their safety and all these. Now, we follow this based on something which has been developed by National Characterization Laboratory. They have an assay casket, and that's a kind of a protocol that we follow. Size matters and compositions in nanotechnology. So to me, and it can vary. If you're asking some other people, then they may have a different opinion about it. But to me, nanoplatforms can be classified in two different ways, based on size, based on composition. In size could be extravascular or intravascular. So anything below 100 nanometer would be extravascular. Anything beyond 150 nanometer, they will be vascularly constrained particles. And then in terms of composition, you will have soft type and hard type particle. Soft type particles are typically polymeric, self-assembled, dendrimers, micelles. Hard type particles are metal crystals, oxides, sulfides, and those are typically hard type particles, and their interaction with the biological membranes would be slightly different than the soft particles. This cartoon shows how these vascularly constrained particles can stay within the vasculature. And if you think about it, this as a blood vessel, and these are red blood cells, and these are nanoparticles, and they'll be restricted by their size because they are within 200 nanometer range. But if you think that they are 5 to 50 nanometer in size, and they will probably leave the vasculature and try to accumulate within the tumor. So the general this is the understanding is renal clearance would be when we have a molecular weight cutoff is somewhere around 50 kilodalton or 10 nanometer. So anything 10 nanometer or beyond, they will be rapidly cleared through the renal pathway. Now, anything 10 to 200 nanometer, that's probably the optimum size, and they can be taken up by what people call EPR, or enhanced permeability and retention factor, which is the leaky vasculature of the tumor. And then anything beyond 250 nanometer, there's a possibility that these particles will generate some problem in vivo, and they can create some PE problem, or they can create some toxicity. And since these are three-dimensional in property, so human immune system will look at them as a foreign substance, and they will start to generate some complement activation problem. So let's start with an extravascular nanoparticle. The question is how far below we could drive the particle size down. So it is one example, and that's a very, very early example. It's one of the earliest example of making polymeric nanoparticles targeted. And back in 2003, 2004, we published these works. So here we took a diblock copolymer. where one part is hydrophilic and the other part is hydrophobic. And then these particles self-assembled into micelle. And those micelles, when we did some intramolecular surface cross-linking, then these micelles formed a much stable nanoparticle of 40 to 60 nanometer in size, which we call shell cross-linked nanoparticles. Now, when these particles were conjugated with this PTD, which is a protein transduction domain sequence, this is the peptide sequence that we conjugated, and as you can see that their intracellular delivery was possible, and you can pretty much see that these particles were FITC leveled or fluorescein leveled, and you can see the particles being taken up by the cell when they're conjugated with protein transduction domain sequence. Very recently, what we did, we used another surfactant molecule, and during the cold self-assembly, the particle sizes were brought down to 16 to 20 nanometer in size. So you can tune the properties of these particles the way we want it. We want 50 nanometer, we can give you 50 nanometer. We want 10 nanometer, we can reduce the particle down by using smarter chemistry. And these are the TEM and AFMMA shows that the particles are polydispersed because these are a polymeric particle and they are not hard particle like polystyrene beads or something. So you would see a lot of distribution, but they are spherical in nature. Now this is a very interesting example, again, very early, 2003, so 11, 12 years back. What we did, and at that time, we thought that folic acid might be a good targeting agents to bind or find and bind the cancer cells, but it turns out it's not because it's everywhere. So what we did, we conjugated these particles with folic acid, and then we did some in vitro studies in cells. So here, it's pretty interesting that when we incubated the particle at 4 degrees, you can see that the particles are sticking outside the cell, right? And because their receptor-mediated endocytosis process is not active because we are doing it at 4 degrees. Now, when we increase the temperature at 37, you can see these particles, they are going inside the cell pretty easily, and there's no problem. So that tells you that that these particles were being taken up by these receptor-dependent endocytosis pathway, and we can prove that pretty easily. Now I'll go skip this slide, and we'll try to understand this. So now let's talk a little bit about that. We talked about that size is important. Now, this is one example where that will tell you why size is important. So, sentinel lymph node imaging. How many of you know what sentinel lymph node imaging is? Yes. So that's a yes and no. But absolutely, exactly. So yes. So that's a sentinel lymph node, and she's absolutely right that that's a very important thing that any lymph node there are many lymph nodes around the human body, and if you're looking at them like even for prostate cancer or breast cancer, then typically if you're trying to, for breast cancer, say for example, if you're trying to look at axillary lymph nodes, then if the person has their cancer cells are metastasized, then there's a high probability that their lymph node will have a cancer cell positive. So how they test it? By a process called needle biopsy. So they would blindly, in the clinic, the doctors, they will blindly poke at the axillary region and then try to find the lymph node and then take some tissue out and then do some histology to confirm whether they have any cancer cell or not. So highly important, but the question is, the whole process is totally dependent on the skill set of the doctor, and it's not reliable at all. So the goal was to see whether that invasive procedure can be replaced by a non-invasive technique where you don't have to poke a needle at all. So we had two approaches, and one, looking at non-invasive imaging, and two, whether it is possible to detect or guide the doctor by using some real-time imaging. So what we did, we thought that it can be done by using a technique called a photoacoustic imaging. So photoacoustic imaging is something which is a combination of ultrasound imaging and optical imaging, and it kind of solves the depth penetration issues with for the optical imaging, because the response that you're getting back is ultrasound and it's not light, and so ultrasound doesn't have a depth response issues. So some other topic, but what we thought that it might be interesting to see if we can use a photoacoustic imaging to identify these things. So what we did, we made 3 different gold nanoparticles. So as we know that gold has unique optical properties, it has a great surface plasmon resonance, so it can be used with different kinds of optical techniques, right? So we made 3 particles, one with 300 nanometer, the other is 150 nanometer, and the smallest one was 80 nanometer in size. So look, here is what's happening. Oh, what happened there? Okay. Turns out I don't have the slide. All right, that's not good. And then what we had, another one that is an even smaller particle that was somewhere around 10 nanometer in size. So this is what happened, you see. This is a photoacoustic image of the region where the doctors would be looking at. So this is where the lymph node would ideally show up. This is a 2 millimeter of the scale. The blood vessels are seen because they have hemoglobin in it. And then we inject the particle here. Within 2 minutes, you can see the lymph vessels. And these are clearly seen that these are the yellow stuff is the particles trafficking within the lymph node. And then this thing is the sentinel lymph node, which was not visible in this image because the gold particles were not present in this. So this is within 2 minutes. So that kind of gives you an example that how the doctors can envision doing a real-time imaging, and by doing this, the whole process can be guided because this is so fast, the clearance is so fast that within 2 minutes doctors know that where the lymph node is, and then that will help them to poke the needle right at the same place where they would like to be. And then within 210 minutes, as you can see, that this contrast is completely gone. That means these particles are being cleared from that place. Unfortunately, I don't have the other slide. I'm not sure what happened, but in the other slide, we clearly showed that for these particles, the tiny particles, you can see the lymph node, but for these particles, the lymph node was not visible at all. Because since these are restricted by particle size, these are 150 or 200 nanometer size, these are so big that in the lymphatic transport, these particles were completely stuck, and there was no transport mechanism at all. Yes, I think you have a question.
So how do you get the particles in the body, and how can you ensure they localize to whatever region you want to keep it?
So yes, so these are not IV. These are not intravenous injection. These are intradermal. So it's typically given right. You just take the skin out, lift the skin, and put the stuff in. Inject your nanoparticle right under the skin. Once you put it in intradermally, then what will happen that the lymphatic vessels, they will take up these particles automatically. And then and the transport is very slow because the lymphatic vessels are very, very constrained. So what will happen that once, if you're using a bigger particle, then they won't travel. If you're using a smaller particle, they will travel fast. and they will find, and they'll be taken up by the lymph node, because those are the draining lymph nodes. So they will take up all these things that are being, they would find as a foreign substance. All right, so the next thing is that how early we are able to detect. So we've been talking about early detection, and this is how, what we're going to do. So this is the question, that is it really possible to detect neo-angiogenic vessels? How many of you know what is angiogenesis is? You already answered. Yes. Okay. So formation of new blood vessels. Okay. So it's a natural process, right? And we can use it for in our favor, and so even if there is a the tumor formation, there will be one point when the vascular, there would be the formation of the new vasculature, and if we can target the formation of the new vasculature, then we can start the treatment pretty early stage, and we can develop a therapy for that at a very early stage, right? So in this example, what we're doing here, we're using again a gold particle, and this is I call a particle-in-particle approach, where we are putting a tiny gold 3 to 4 nanometer size particle coated with a lipid, and then we have something called alpha V beta 3, which is an integrin antagonist, and that binds to the vitronectin receptors present within these angiogenic vessels. And the binding ligand that we are using, it's a very high affinity, this binding ligand. It has a binding affinity of about 10 nanomolar, but when we put 300 copies, it kind of becomes 50 picomolar, so which is very, very high, and that can go and bind to different kinds of angiogenic receptors or alpha V beta 3 receptors. So this is what is happening, that we're showing that early detection of immature nascent angiogenic vessel is possible with photoacoustic imaging and a targeted gold nanobeacon. So here we used a mouse model, and we injected or implanted a stuff called matrigel, and that kind of induces the formation of angiogenic vessel when we use some kind of a growth factor. So this is within 14 days, you would see the formation of the new blood vessels. So within 14 days, you see these are the new blood vessels you are seeing, baseline image with photoacoustic, 720 nanometer laser operating. Now here we are injecting this alpha V beta 3 targeted gold particle. Now, if you see carefully, then you will see that within 3 hours, these red arrows, if you follow these, and they are pointing to small neovascular sprouts that are rising from immature angiogenic vessels, and those vessels have very, very little or nascent blood flow. Why? Because if you look carefully, then you will see that they don't have any full, complete circulation yet, because they are not a complete blood vessel. They are just forming, they're sprouting blood vessels. So we are targeting those vessels which are just forming. So that's even one step before targeting angiogenesis. And within 5 hours, you can see that these particles are even more, these vessels are even more prominent. So that tells you that with a very sensitive imaging technique and a super sensitive nanoparticle, targeted nanoparticle, you should be able to detect very early biochemical changes in a living system. And we histologically confirm the whole thing. So here is one example where we prepared manganese-based contrast agents, where we used different kinds of manganese, either manganese oxide or manganese oleate type materials to encapsulate it again within a lipid-coated particles. And then, these are the TEM and AFM image shows that you can see that the lipid coating is seen here, and the manganese oxide particles are seen inside these lipid particles, and these are the AFM particles. So these are, as we know that manganese is paramagnetic. How many of you know that how many free electrons or how many unpaired electrons are there in manganese? Complex science. How many are there in gadolinium? Any idea? In +3 oxidation state. So in typically, gadolinium is the most widely used MR contrast agent, and that's used in the clinic. Manganese is also there, and there are some manganese compounds, they were approved at one point of time or other. So gadolinium has 7 unpaired electrons, manganese has 5 unpaired electrons. And so those are responsible for generating T1 weighted or bright MR signal, right? And so before we talk about the manganese result, I will give you a brief background on the drug system, and then we can combine the image-guided drug delivery stuff. So in this drug platform, what we're using, that we have a phospholipid prodrug. So we have the drug that we will couple at, so this is the lipid, right? And then we are coupling it at the hydrophobic end of the lipid. And then we're putting it as part of this nanoparticle, which is a lipid monolayer. So what happens that way, we're making the drug more hydrophobic so that it doesn't come out during the circulatory translation or transition. And so it's hydrophobic. It's not going to come out or burst release from the nanoparticle. It will only come out when this nanoparticle would come and start interacting with the cellular bilayer. What happens that this is a hemifusion that happens. So this is nanoparticle, which has a lipid monolayer. This is cell, which has lipid bilayer. And they kind of, when they come in contact, they kind of go and fuse together. And during that fusion, all these drugs get transferred to the cell. Now, once they're in the cell, and if it is a cancer cell, and there would be enzymes that will cleave at a particular region, and that is here at an ester bond to release the active form of the drug. And that's how the drug gets activated. So here, I can show you that this is one nanoparticle caught in action, interacting with a cell, and you can pretty much see the junction and how they're interacting at the cell level. Now this is what I was gonna show you, that I call it find, fight, and follow. Again, theranostic. And we talked about the manganese particle that will be used for targeting, say, angiogenesis in MRI. And then we talked about a drug, prodrug. So this is what is happening. So this was done in a VX2 tumor rabbit model. This is the rabbit was implanted with a tumor called VX2, and this is this picture, this image. This is an MRI image, which shows this is where the tumor is, and then these tumors were being targeted by the manganese particles. This yellow stuff is the nanoparticle targeting the VX2 tumor. Now, and this is a 3D neovascular map showing the presence of the angiogenesis in this tumor. Now, this is no therapy, but when we apply therapy, as you can see, that this response is completely gone here. So the drug is working. So if you compare this with this, the neovascular map clearly shows that the angiogenic expression is dramatic in this case where there is no therapy, but when we are treating it with therapy, the angiogenic expression was almost not there. Yes? Yeah. So, so how we are targeting it, again, we talked about that alpha v beta 3 targeting ligand, right? For the gold particle example, the same targeting agent, homing agent we're using to target these VX2 tumor as well. These are IV injection. These are not intradermal or anything. So they would be under full circulation. The good thing about these particles are that they have a very rapid clearance. So within 1 hour, 1.5 hours, they would be completely gone from the blood circulation. So if you think about a fast pass mechanism, you know fast pass mechanism? No. So fast pass mechanism, what happens that when you drink something, say for example Gatorade or juice or something, so you drink and they will immediately go to guts, okay, and then they will start being distributed to the other areas. Now, since these particles, the way these particles are made, that they have a very rapid clearance. So they would have, and the clearance in the terms not from the body but from the circulation. So from circulation, they would be completely cleared, but then they would start finding the right site. Now, since these are targeted to the alpha v beta 3 receptors, so all they would do, they would go and find those receptors, and they would latch onto those receptors. There would be some non-specific interaction for sure, and there would be some accumulation in the liver, which we cannot avoid, and that's probably an intrinsic property for all nanoparticles. It cannot be avoided. But significant amount of the nanoparticle will be deposited on the tumor by the active targeting mechanism. Does that answer your question? I don't remember that exact number, but it'll be somewhere around 20 to 30% of the nanoparticles that were injected that went to the cancer cell, and that's a huge amount. Because what the number says that if you're thinking about it, the dose was 10,000 times less than a clinical dose. So that means the clinical particle, the drug, this is the drug TNP 470. That was, and what the clinically that has been injected by using nano and by using targeted nanoparticles, we are reducing down the effective clinical dose by 10,000 times. What does that mean? That means that you are bringing down the chances of having side effects dramatically, because you are not delivering. What we're looking at is the amount of the drug being delivered by one single nanoparticle and not by one single particle or one single drug, right? So for when you are delivering the drug as a small molecule, then you may have to inject a whole lot more. But when you are delivering through nanoparticle, then all you care about how much you're putting inside one nanoparticle, and that's what matters. So even if it's a 20% or 30% that mix to the tumor, that's a dramatic effect, and that's what we're looking for. Does that answer your question? Right, good. All right, so hold on, let me see. Yes? Oh, that's just it's a cartoon. No, that you cannot have the nanoparticle and the cell similar size. So those are not cells. Those are lipids, lipid bilayers. So those are not cells. Yeah. So that's a great question. Yeah. So those are not cells. Those are particles. So the lipid monolayer particles interacting with bilayer lipid particles. So that's like typical like a liposome, but we're kind of mimicking the cellular system. Okay. I think I'll go ahead and how much time do I have?
Oh, you...
A lot?
You have about 5 minutes, but we can go into...
We have 5 minutes? All right, so I got to finish this.
Oh, you can take your discussion time in there. So
Sure.
You have split by 9:45.
Okay, all right. So I'll just give you a brief of, I'll switch gear, and we'll talk about cardiovascular problem. So this particular work was done for targeting atherosclerotic plaque. So I remember that I was sharing the session for Jun Kong, and he was talking about all those atherosclerosis and putting stains and all these things. So that was very good because it kind of set the stage, and I don't have to explain all these things anymore. So what we did here, we were using bismuth nanoparticle because bismuth is a heavy metal, and that can be used in conjunction with computer tomographic imaging. And CT is one of the most ideal modality for using or for scanning heart. Can you tell me why? Why not MR? Why CT is good for scanning your heart? It's good, very good, because MR is very slow, and heart beats, right? So you cannot capture the images in one bit, and CT is really fast, and you can take in seconds, and that is good, and that's why CT is probably the most ideal technique for scanning heart. But CT has problem as well. For example, CT cannot distinguish. CT has a very poor soft tissue contrast, so that's why you cannot get any good information if there's any soft tissue related problem. So how can we solve that? We can solve that by making some smart CT contrast agent. So here, what we're making is something we called a bismuth nanoparticle, and these are 200 nanometer in size. And they are targeted with an anti-fibrin antibody because we're targeting clots present in the atherosclerotic plaque, and in clot you have fibrin present, right? And that's what we're trying to target. So what we did first, that this is a carotid endarterectomy specimen that were taken out of a patient from in the clinic, and then this is the optical image of the plaque. And if you can see that these are the soft tissue, but this part, you see these are garbage. These are the plaque and all fatty food, Big Mac diet, and all these things that goes in there. So our idea was to target that part. So this is what is happening here. You can see that this is a CT image of this thing with no particle, but then and this is another one with targeted with particle, and you can see this is the red one is calcium because there would be calcium deposit, and this yellow stuff is the bismuth particle. You can see targeting the fibrin present in this specimen. So. And we're using something called a spectral CT. I don't have time to go over it. It's a kind of advancement of CT that can distinguish or can color, put some color into the context of the CT. So that's why we're seeing color here. So we were able to distinguish between the targeted contrast agent and calcium. Now we did the same thing with in vivo, where you see this is a rabbit. We created a blood clot inside a femoral artery of the rabbit, and then we targeted it using this bismuth particle, and you can see that these bismuth particles are clearly seen inside the vessel, and that was enhanced here. So that was really one of the earliest example of doing targeted contrast agent imaging with computed tomography. So with that, I think I need to stop. You guys are, I mean, I can talk another 1 hour, but that's all right. But I was just going to give you a little bit to talk about this, how we are using scorpion venom against cancer. And that's everybody's getting excited about these things, but that's okay. So the bottom line is we just try to cover a few little things that how nanoparticle works and how it can be combined with imaging and therapeutics, and how can you use it for detecting some early biochemical changes for cancer and cardiovascular disease, how nanoparticle size affects, and how the surface chemistry works a little bit, and the bottom line is it's a very highly interdisciplinary area of research. We do chemistry, we do, I call it in silico to in vivo research, because we start from computational studies, and then we do synthesis, pure chemical synthesis. We do a lot of biological stuff, and then we go for preclinical stuff, and then we go for clinical studies. So it's a full circle. All right, so these are my collaborators, and some industrial collaborators, WashU collaborators, Carl, and then UOI, and these are the funding, and I need to acknowledge them, and that's about it. And thank you so much. So I will take any questions that you may have.
Questions for Dr. Pan?
Yes, yes.
So I saw on one of your slides you mentioned 250 copies of folic acid.
Yeah.
Why did you pick 250?
That was optimized for that, and that was an accurate number. So at that point of time, we're trying to compare between a small molecule chemistry and nanoparticle. So think about when a synthetic chemist make a small molecule. Okay, what does that person do? Go for an NMR, does FTIR, UV visible, mass spec, done, right? Pretty much you get everything. That's the kind of thing we're trying to do with analytical autocentrifugation. And you can get all those information. Molecular weight of a single nanoparticle, yes. The number of ligands on the surface, yes. And so that's how we're getting, and that was optimized to have 250 copies of folate. And that kind of you'll have.
So in your other, peptide ligand, you had 300 copies.
Yeah.
So do you think it was the number of ligands per, nanoparticle that was more important, or the apparent affinity or avidity that you were? That's
a great question. So first of all, those are different particles, different size, different particles. So the folate particle was only 20 nanometer size. Mm-hmm. The other particle is around 200 nanometer in size. Okay, so that's more interesting. Yes, I would say both. So your affinity, and it really depends what you are targeting. If you're going after a cancer target and you are saying that okay, you have a millimolar range binding affinity, no, it's not going to work. Let's face the fact. If you have low micromolar or nanomolar, might work. Okay, so the nanomolar would definitely work. Micromolar still would work, but you need to put a lot more. But again, it really depends. It's a very fine line. It really doesn't. It's tough, because if you think that you will put 1,000 of targeting agent and it will bind more, it's not going to work. So you need to put it an optimized number of nanoparticles, and that's a lot of optimization studies that are required. And then again, you might need some kind of a linker molecule in between the targeting agent and the nanoparticle, because the targeting agent might be buried completely inside the nanoparticle, and it may not be interacting with the receptor at all.
Do you have a high throughput method for this optimization?
No high throughput. It's all very, yes. Yes.
If there's a question there,
yes.
Can you explain that scorpion?
Yeah, so we didn't even talk about it. So, yeah, so we're doing some venom therapy, and we're isolating some toxin from scorpion and some other deadly species like snake and frogs, and also bee venom. And we're collecting those toxin and then finding the active component of it. And then the active components are being put in the nanoparticles, and we're delivering that thing. It's highly poisonous. So typically, if you're looking at small molecule therapeutics, you would find an IC50 in the micromolar range, but for these, you would find it in a nanomolar range easily. So the goal is really to control their potency. And that's what we're trying to do, that using nanoparticle approach, we're delivering these and then controlling their highly effectiveness, let's say. Does that answer your question? And we have used breast cancer cell lines and melanoma, and it works really well. Yeah.
So in that case, how is if they kill cancer?
Yeah, that's one of the things that I was in early slides. We were trying to mention that we need to spare all the normal cells, and that's the problem with today's conventional therapy. That it works. For example, if a person is going through the radiation therapy, then it works, but it also kills all the surrounding cells. Right? We cannot let that happen. So the idea is, the nanoparticle will bind to only the cell that is intended to bind, and that's we're doing through size exclusion and by doing receptor targeting.
For the neo-angiogenic vessels,
yeah.
In your mouse model, you use matrigel. We know that matrigel is derived from seaweed, and we really don't know its composition. Why do you use matrigel instead of any other extracellular matrix that help with the angiogenesis, like fibronectin, vitronectin, collagen 1 or 4?
We can use those, no problem. Yeah, because it was well, matrigel is it's a very common thing to use in the lab for some other stuff. So we had it with us, but like I think I mentioned that it had some other growth factors, and that was generating the angiogenic expression. So it's just not the matrigel. So you can potentially use a collagen matrix and then use that. I think it's a BGFF growth factor, and then and then that will generate angiogenic vessels. So that potentially you can use anything. But that was a cheaper model, so that's why we approached that.
Also, there was any immune response in this rat, or
no.
They were naked?
They were naked, but these particles don't generate any immune response, because those are kind of immune silent. Because we kind of have a pretty good idea what generates immune and what doesn't. It's one part of my research, and we're very dedicated of understanding that what really triggers the immune response. Is it the size? Is it the surface? Or is it all the gadolinium that we're putting on the surface? We have a pretty good idea that what it does, and there was no immune response, not in vitro, not in vivo.
Any other questions?
Yes.
You said you were about the hard type.
So the goal is basically to, I didn't explain it because that's a completely 1 hour talk it will be. So the idea is, think about a situation when a person is having chest pain. How do you know that it's coming from heart or it's coming from something that you ate last night? Is it a GI problem or is it coming really from heart? We don't know, right? So what would a person do? Run to the hospital. And what they would do over there, they would check your blood pressure, blood sugar, and they will, probably they would check CKMB or something, those enzyme tests for looking at, whether that person is going through a heart attack or not. Most of the times, if that person is not going through a heart attack, those results will come back negative. So you really don't know whether that person is really having a heart problem or not. So what they would do, they would ask you to come back next day and run in a treadmill for doing a stress test. Think about a situation when the person really has a heart problem and you're asking that person to run in the treadmill, okay? And that's probably not the real ideal situation. Most of the times, they would find a problem if there is a stable plaque. If there is no stable plaque, nobody can identify those things. Those are called vulnerable plaque. So those vulnerable plaques are most deadly because no way we can detect those things. So that's what we're trying to come at, that if we, and right now CT cannot do that, but CT can do that if we combine CT with some other advanced techniques, like these spectral CT that we just talked about a little bit. And that gives color because it can distinguish between the calcium and your, if there is really some vulnerable plaque, and if your contrast agent is binding to the plaque, then it can really differentiate between these two. So there are many, many different factors. Is that what you're asking? I mean, you're asking something else? It's all same. It's all same. It's IV, injected IV. It'll go, and since these are, again, size exclusion, first thing is size exclusion. The second thing is receptor-mediated targeting. So the size exclusion, 200 nanometer size, it will find all the problems in the vasculature and will bind to that.